Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us as we make your life easier and reignite your passion for primary care.
Welcome to the Time to Make an Apple Crumble Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
You might be staying up to date with your best mate.
Doing your PDPs with your hive of bees.
Or reading a pearl whilst doing a twirl.
We're here for some discerning learning.
Grab a tea, CPD. Enunciate. There we go. I think that works.
Lovely. That was lovely.
Here's what's bubbling up as we dive in search of our pearls for the second time this month. Obesity and weight management in pregnancy. NICE produced updated guidance on nutrition and weight management in pregnancy earlier this year, so we're going to share what NICE suggests.
Cognitive behavioural therapy for menopausal symptoms. Hero, villain, or just difficult to access? When NICE updated its menopause guidance in 2024, it recommended cognitive behavioural therapy as one tool to support women experiencing menopausal symptoms. This received a mixed reception in the media. We're going to take a deeper look later on.
And we start this week with our third pearl of the month, and we're talking about obesity and weight management in pregnancy. And we're joined once again by Hussain Al-Zubaidi. So hi Hussain, how are you doing? You right?
Very well, thank you. Yourself?
Yeah, I'm good, thank you. So I wanted to start by asking you, if we were watching a movie of your life, then what would we all be shouting at the screen right now?
Well, there's a famous line at the end of this movie. I wonder if either of you can guess it, but it's for a moment there, I thought we were in trouble. Any ideas what film that's from?
Not a clue.
I don't know.
I should know that.
Is it an action movie?
Yes.
No, I don't know.
It's a Western. It's from Butch Cassidy and the Sundance Kid, and it's The Last Line. And any of you that have watched that film, if you haven't, I'd highly recommend it. But it's basically a lot of recent turbulation and stress, and then for a moment they think everything's fine, but then they find out it later isn't.
Okay.
So hopefully I won't find out the last.
Oh,
I
God.
was going to say, yeah. Because then the
Doesn't
follow-up
sound
question,
too positive.
because then we say, why should we be shouting at the screen for you, Hussain? What's going on?
But no. All's well.
You're okay.
Good.
All right. And then, Ali, what would we be saying at the screen if we're watching your media?
Oh, gosh. You look like you need a rest. Go and have a nap. I don't know what movie that happens in.
Oh, bless you. Well, you're looking fabulous. So don't worry about that.
Thank you, Nick.
Right. Now then, this pearl took me 12 minutes and 14 seconds to read. So that's a good few squats, mountain climbers and burpees, I would reckon. So now NICE published its guidance on nutrition and weight management in pregnancy in January 2025, which is NG 247. And we're going to summarise the key elements for us in primary care. Now, this article was updated in August 2025. So let's start with the headlines. Both excess weight gain and low weight gain during pregnancy carry risks for the mother and the baby. BMI assessment at booking is essential for risk stratification and appropriate care planning. Healthy eating and physical activity are key components of weight management, but should be approached with sensitivity. So, Ali, what are the key recommendations in pregnancy?
Well, for pregnant people who have a BMI of 30 or greater at booking, they should be offered screening for gestational diabetes. People who have a BMI of 40 or greater at booking, there should be a referral considered to specialist obesity services. Importantly, we shouldn't routinely weigh patients unless it's clinically indicated. We've got more on that coming up. And intentional weight loss is not advised during pregnancy due to potential adverse effects on the baby.
Hussain, why does weight matter in pregnancy?
Weight management in pregnancy plays a crucial role in minimising complications. Both excessive and inadequate weight gain in pregnancy is linked to adverse outcomes. Excess weight increases the risk of gestational diabetes, hypertensive disorders, and large for gestational age babies, while low weight is associated with small for gestational age babies. Women entering pregnancy with a BMI in the overweight or obesity categories are at higher risk of complications, including caesarean section and postpartum hemorrhage. And pregnant women with obesity also have an increased risk of venous thromboembolism, preeclampsia, miscarriage, wound infections, and higher rates of mortality. That's from the British Journal of Obstetrics and Gynecology in 2019. Addressing weight proactively during the conception phase can mitigate some of these risks.
I think one of the trickiest things about this topic is what an emotive and potentially sensitive subject it can be to bring up, isn't it? I wondered if you've got any advice, Hussain, on how we can go about discussing this with patients.
Yeah, you're absolutely right, Ali. Many women may feel uncomfortable discussing their weight, so it's essential to create a supportive and non-judgmental environment. The first antenatal appointments provide a key opportunity to assess BMI and discuss weight-related risks in a way that empowers rather than discourages patients. We want to look in that first antenatal appointment to measure BMI, use sensitive language to avoid stigma and encourage engagement, explain why BMI matters in a way that is patient-centered, and offer written and non-verbal feedback on BMI if patients prefer not to discuss it verbally.
Now, I don't know about you, Hussain, but at my surgery, the antenatal care is midwife-led. So should this be being done by our amazing midwifery colleagues?
Yeah, that's correct. And that's the case in my surgery, and I suspect for the majority. But I think it's really important that it doesn't mean that we don't take the opportunities when we do see patients living with obesity and overweight during that phase of pregnancy, just to reiterate and reinforce some of the messages and, again, continue that, environment that is safe for them to have those kind of discussions if they choose to engage in them.
You mentioned earlier the option, if patients prefer not to discuss BMI verbally, that we can offer written or non-verbal feedback. I'm just wondering, what would non-verbal feedback on BMI entail?
That's a really good question, and that's sort of the terminology used in the NICE guidance. I thought maybe it was an interpretive dance to start off with, but it's enough. What they're instead talking about is during sort of face-to-face healthcare professional consultations to provide BMI results on a printout or a visual chart, to record it in the patient's handheld maternity notes or display it on a screen, something where they can visually put the number into something that they understand. We've all seen those BMI charts before with the different sort of colour groups. There's various different tools, including ones for those with learning difficulties and other languages available.
Okay, I think that makes sense. So it's about sort of making the information available to people should they want to look at it.
Yeah, and may not want to engage in that verbal discussion because of concerns or sensitivities.
Got it. Okay, so thinking about preconception counselling, NICE emphasises that weight loss during pregnancy is not recommended due to potential adverse effects on the baby. However, addressing weight proactively during the preconception phase can mitigate some of the risks. We're encouraged to highlight the significant health benefits of weight loss before pregnancy. And in June 2025, there was an MHRA alert which released guidance for women using GLP-1 agonists and also planning pregnancy. Last month, Hussain, you told us about it very elegantly, so I was wondering if you would just mind recapping that again.
Of course, when you ask so nicely. Yes, so the MHRA alert told us that GLP-1 medication should be avoided during pregnancy due to lack of safety data. The MHRA recommends a washout period after stopping these medications before trying to conceive. Now, this differs depending on which GLP-1 or GLP-1 mimetic. So, for semaglutide, you stop at least 2 months before pregnancy. Tirzepatide, 1 month before pregnancy is when you should stop. And liraglutide has no washout period required, so stop prior to attempted conception.
And why is that, Hussain?
Well, the MHRA highlighted some animal studies which identified harmful effects on the developing fetus. Further evidence is needed from human trials, so watch this space.
Now, the RCOG guidelines on the care of women with obesity and pregnancy advises checking weight and BMI as part of routine preconception care and supporting women to optimise their weights between or before pregnancies. Now, this is associated with a reduced risk of stillbirth and hypertensive complications and an improved likelihood of successful vaginal birth after caesarean section. And that's from the RCOG Green Top Guideline 72, which is CTG 72 from 2018, and the British Journal of Obs and Gynae from 2019. Now, women with a BMI of 30 or more should be given advice on the risks of obesity during pregnancy and childbirth. So what about planning to get pregnant after bariatric surgery, Hussain?
The Royal College of Obstetrics and Gynecology advises waiting at least 12 to 18 months after bariatric surgery before attempting pregnancy to allow both stabilisation of body weight and the identification and treatment of any nutritional deficiencies that may not be evident in the early months. That's from the British Journal of Obstetrics and Gynecology 2019 too.
So weight changes in pregnancy are obviously expected. However, there are some indications for more regular monitoring of weight and some cases where a more detailed assessment might be required. So the clinical indicators for regular weight monitoring during pregnancy, and this isn't an exhaustive list, but this is what NICE suggest. We've got gestational diabetes, hyperemesis, and patients on thromboprophylaxis. So what about excessive weight gain and low weight gain in pregnancy, Hussain?
There's actually no clear definition or consensus around what constitutes excessive weight gain in pregnancy. However, if it is suspected, NICE say that we should assess physical and psychological factors contributing to weight gain, encourage a balanced diet and appropriate physical activity, monitor fetal growth to assess risk for large gestational age, consider gestational diabetes testing, which we'll come on to in a bit. If there's low weight gain, then we should explore reasons such as nausea, vomiting, mental health issues or underlying medical conditions, encourage nutrient-dense foods and ensure adequate calorie intake, and monitor fetal growth and consider additional support if concerns arise. For women asking for more information on expected weight change in pregnancy, NICE recommends that we signpost to the National Academy of Medicine's 2020 paper on expected gestational weight gain based on pre-pregnancy BMI.
Now, maintaining a healthy diet and staying active during pregnancy can contribute to better outcomes for both mother and baby. Nutritional guidance should be practically and culturally sensitive, ensuring that women feel supported in making changes. So let's consider healthy eating first. And for this, we've not only used the NG247 from NICE, but also the RCOG Healthy Eating and Vitamin Supplements in Pregnancy from 2022. And as you'd expect, a balanced, varied diet is the order of the day. So we should encourage pregnant women to eat a wide range of foods, including plenty of fruits and vegetables, also whole grains, lean proteins and dairy to ensure both mother and baby get essential nutrients. So what else can you tell us, Hussain?
Well, Nick, we should advise pregnant women to limit high-fat and high-sugar foods. We would advise reducing foods with high fat or sugar content to help manage weight and lower the risk of gestational diabetes. I'd say this is probably useful advice for any patient, to be honest. Now, folic acid supplementation, we need to stress the importance of starting folic acid supplements before conception and continuing during early pregnancy to reduce the risk of neural tube defects.
And should we be prescribing higher dose folic acid to women with obesity?
Older Royal College of Obstetrics and Gynecology Green Top guidance on the care of women with obesity in pregnancy recommended that women with a BMI of 30 and over take folic acid 5 milligrams from 1 month before conception and for the first trimester. NICE concluded that there's no evidence to support high-dose folic acid for those with a BMI within the overweight or obese range, and the standard dose of 400 micrograms is sufficient unless other risk factors for neural tube defect or congenital malformation are present. Those who have had bariatric surgery may require specialized advice on folic acid and other micronutrients before and during pregnancy. It's recommended to consult the patient's bariatric surgery unit for guidance.
And what about vitamin D supplementation?
Yes, we should recommend vitamin D supplements, especially for those at risk of deficiency, to support bone health and immune function. There's insufficient evidence to recommend a specific dose of vitamin D, but current UK guidelines advise 10 micrograms or 400 international units daily during pregnancy and breastfeeding.
And if I've got a patient with gestational diabetes, is there any evidence for the best diet that they can follow?
So there's no specific best one diet for gestational diabetes because there's no convincing evidence that one diet is superior to another when it comes to managing gestational diabetes. And also we need to be mindful of our patients' cultural and nutritional profile. And so it's about trying to encourage them to make changes on their diet based on some of the information you've given around ensuring we have nutrient-dense, lean proteins and a good source of things like iron, calcium, etc.
And of course, that'll come out of individual conversations with different patients. It's not going to be a one-size-fits-all, is it?
Exactly, yeah. Because imagine trying to speak to your patient Hiba from Pakistan and encouraging her around a Mediterranean diet when that's not the food she loves, cooks and eats. So we have to be mindful of the individual and just supply them with that information and let them take that lead.
Excellent. Okay, so that's healthy eating ticked off. So what about physical activity?
Yes, you know me. I'm very keen on movement. Well, NICE tells us to encourage at least 150 minutes of moderate intensity activity per week, encouraging minimizing sedentary time, and suggest walking, swimming, or prenatal yoga. Tailor advice based on pre-pregnancy activity levels and preferences. The Active Pregnancy Foundation has a wide range of resources for both patients and healthcare professionals. I in fact know the two ladies that lead that, Sally and Marliese, and they are incredible, and the resources on their website can be really useful for patients to feel more reassured and empowered to move a way that they like to move. An interesting point to highlight is that the guidance highlighted that although nutrition and physical activity did not show significant efficacy in managing weight during pregnancy in randomized control trials, they were associated with reduced rates of gestational diabetes, preeclampsia, and large gestational age babies.
Pregnant women with a higher BMI are at increased risk of developing gestational diabetes, which can lead to complications if it's left unmanaged. Early screening and lifestyle interventions can help improve outcomes. So we should offer testing to patients with a BMI of 30 or more at booking, and we should offer testing to those with additional risk factors, which are outlined in our Diabetes in Pregnancy, including Gestational Diabetes article. If excessive weight gain is observed, even if the BMI at booking is below 30, we should also consider testing for gestational diabetes. And we should also provide individualised dietary and lifestyle advice for those who are diagnosed.
For some women, specialist input is required to manage weight-related risks in pregnancy. Timely referrals can help ensure appropriate support. BMI of 40 and over at booking, we need to consider a referral to a specialist obesity service. Refer to dietitians, midwives or physiotherapists for tailored support, and encourage access to peer support groups and digital resources.
And breastfeeding's got particular benefits for women living with obesity and their babies, hasn't it, Hussain?
Yeah, doesn't it? The first benefit is reducing risk of maternal type 2 diabetes later in life. Meta-analysis of observational studies showed that any breastfeeding reduced the risk of type 2 diabetes by 27%. With an even greater benefit seen in women with a history of gestational diabetes. That's from Diabetes, Obesity and Metabolism in 2021. The second benefit is a reduced risk of obesity in adolescence and adulthood for the breastfed child, and that's from The Lancet in 2016.
And just thinking about GLP-1 medications and breastfeeding, in June 2025, the MHRA released a reminder that GLP-1s should be avoided during breastfeeding. And for more detail on safe use of medications related to obesity during breastfeeding, see Specialist Pharmacy Service UK Drugs in Lactation Advisory Service, Safety in Breastfeeding. That's a bit of a mouthful. There's a link to that one in the written pearl, and we'll also put a link in the show notes.
So here are your learning points for obesity and weight management in pregnancy. Both excess weight gain and low weight gain during pregnancy carry risks for the mother and baby.
BMI assessment and booking is essential for risk stratification and appropriate care planning. BMI 30 and over offer screening for gestational diabetes. BMI 40 and over consider referral to specialist obesity services.
Healthy eating and physical activity are key components of weight management. but they need to be approached with sensitivity.
Excellent, thank you. And Hussain, your new obesity course is launching very soon. Tell us about that.
Yes, it is on Friday, the 26th of September, which isn't long at all. We are launching the obesity medicine course, and it is a day packed full of really understanding obesity far beyond simply injections and increased BMI, because we know that it's such a complex chronic condition that affects a significant proportion of our population. And we need to be able to better engage with it with our patients, better be able to understand how the evolving landscape is shifting, and know that actually obesity medicine is coming into primary care. With what we've seen, with what NICE have done in technology appraisals, they are opening its delivery. So it's something that we're going to need to get our grips around pretty soon.
And this is something you've been working on for a really long time now, so it's going to be amazing for you to be able to get it out there. So of all the things that you've been working on, which is the one thing that you're most excited about people seeing?
Do you know what? The thing I'm most excited about is hearing from Tanya, who is a patient who is living with obesity and has been on the injections as well as a number of different treatments, and hearing her story. So understanding the perspective of what it's like to live with obesity, the stigma and bias that she's faced all her life, and getting that from the patient and hearing it really changed my own practice, just listening to it during that discussion. I know that for many that will come to the course, it will likely do the same for them.
Excellent. Thank you, Hussain. You take care and we'll see you soon.
Thank you very much.
Cheers.
Hussain.
And now it's time for a group hug. It's the part of the podcast where we celebrate getting through a difficult day in primary care with our best intention story. And thanks to all of you that have emailed in, and also to those of you who've also texted in your stories recently as well. However, we do need your ongoing help to put a smile on everybody's face. So whilst you listen to the story this month, then have a think about what your best intention story would be, and please send it in. And our contact details are in the show notes. So here we go. A best intention story for Nick and the gang, it says here. And this is from CH. As a medical student, I had always struggled with blushing when patients divulged the most intimate details of their lives. I wasn't a prude or even particularly embarrassed. I just seemed to have developed an uncanny knack for turning a shade of beetroot at the mention of, well, anything involving their sex lives. I decided I needed a definitive cure, and this came in the guise of a month's placement at a gum clinic in central London. After consultation of forcing myself to ask, "I'm sorry, I might need some help with understanding that terminology, I'm a country girl," they willingly obliged, and with a widened vocabulary, my blushing rapidly started to resolve. I was cured, or so I thought. Fast forward a few years, and I was happily back in my hometown training to be a GP. A couple came in to see me, struggling with their fertility. We had a frank and detailed conversation about how frequently and how long they'd been trying, any concerns about any previously contracted STIs, any previous pregnancies, and how not being able to have children to this point was affecting their relationship. The consultation was going well. I'd gained their trust, and there was not even a hint of a blush. Until, that is, I progressed with the management plan. I explained to the wife the blood tests required and organised a referral to the local hospital for a hysteroscopy and dye test to check the patency of her tubes. No issues. I turned to the husband. Having located a pot and form for semen analysis, and I explained that he would need to drop into the local lab, having phoned ahead so there wouldn't be a delay necessitating a repeat sample. I then completely inexplicably said, "And if you need help with that..." I'd meant in understanding the process of the hospital receiving the sample, but he and his wife looked shocked at what I'd accidentally implied. And yes, I definitely blushed. Possibly the brightest shade of red ever. Thankfully, they saw the funny side of it, and my assistance was not further required. Thank you for that, CH. That was a brilliant story. What do we say?
I mean, it's kind of easily done, isn't it? Your words just come out a bit wrong sometimes. Yes. But yes, that particular phrasing, unfortunate.
Yes, but the fact you built up that good rapport with the couple, they realised that you'd misspoken, as it were. So thank you for that.
Oh gosh, could happen to any of us, couldn't it?
It could. Are you a GP trainee or do you know one? We've got some exciting news.
We know that GP trainee years can feel daunting and expensive. So Redwell has joined forces with the MDU to provide a free education package tailored to GP trainees, which has been really popular. Nick, can you tell us about it?
Of course, this is the GP Trainee Essential Support Package, exclusively available to GP ST MDU members and affiliates. It's worth £165 and is designed to build your knowledge and confidence to help you pass your exams. So what does it include, Fee?
You get access to the whole of Redwell knowledge. That's over 900 written resources to support you during consultations and with exam preparation. Some of you describe it as like having an educational supervisor in your pocket. There's also a digital Top AKT Topics handbook, which contains topics that the RCGP says people find challenging in exams.
You also get access to 4 on-demand exam preparation webinars that demystify workplace-based assessment, AKT, SCA, as well as statistics and data interpretation.
And from August 2025, we'll be sharing a monthly video bite on common primary care presentations to support your learning even more.
So, who's eligible and how do they access it?
This all depends on where you are training. If you're a GP trainee in England, indemnity is provided through your deanery. But in addition to this, you can sign up for free MDU affiliate membership anytime during your training. You will then be able to access the GP Trainee Essential Support Package for free. And if you're a GP trainee in Scotland, Northern Ireland or Wales, you choose and pay for your own indemnity. Therefore, if you choose the MDU as your indemnity provider, then you will gain free access to the GP Trainee Essential Support Package. Just visit themdu.com to find out more. Click Choose to Join MDU and you can see all the options.
Once you're signed up, you'll receive a code from the MDU so that you can access GP Trainee Essentials as a free member benefit. And when you CCT, if you choose to continue with MDU indemnity, then you'll get a free Red Whale course of your choice or a discount on Red Whale Unlimited to support you in your first year of practice. So, if this is of interest to you, then see the link in the show notes for full information and T's and C's, or search Red Whale GP Trainee Essentials to learn more. And now here's Ali with the Red Whale calendar.
So we've got lots of exciting stuff coming up, including our live obesity course presented by Hussain on the 26th of September. We've got a live GP update course online on Saturday, the 27th of September. IO's presenting that one. That's the last GPU course of the current spring-summer season. And then on the 14th of October, a whole new season of GP update launches. So you can access that on demand from the 14th of October. And then on the 16th of October, Kate and Catherine will be presenting a live on-demand GP update course in the studio. Or also on the 16th of October, there's a face-to-face GP update course happening in Manchester presented by Mike and Fiona. So you could book on to that now and come along to Manchester, my part of the world.
And now it's time for our fourth and final pearl of the month, CBT for menopausal symptoms, hero, villain, or just difficult to access. Now, when NICE updated its menopausal guidance in 2024, it recommended cognitive behaviour therapy, or CBT, as one tool to support women experiencing menopausal symptoms. This received mixed media and celebrity reception, didn't it, Ali?
Yes, one of the things I remember picking up on around the media response was women raising quite reasonably that it feels a bit uncomfortable to be offered a psychological treatment for menopause symptoms, because that almost implies that the symptoms are somehow in the mind or not real or not valid, which of course isn't the case. That's not what NICE is saying. But I think there's an important message for us in primary care there about how we frame this treatment if we are going to offer it.
So we're going to take a look at the evidence for the potential benefits of CBT for menopausal symptoms and consider access issues. And then you can make up your own mind about this. Now, CBT is a brief psychological therapy which is recommended by NICE and the British Menopause Society as a management option for a variety of menopausal symptoms. And that's from the NICE guidance NG23 from 2015, updated in 2024, and also the BMS, the British Menopause Society, their cognitive behaviour therapy CBT for menopausal symptoms from 2019. Now, the written Pearl and the associated article on Redwell Knowledge was updated in November 2024. And you also might like to look at our associated articles, Mental Health in the Menopause Transition and Menopause in the Workplace, both on Redwell Knowledge. So what is CBT, Ali?
Well, the CBT model is based on the idea that the way people feel is linked to how they think about or perceive a situation or a physical symptom, and also to the way they behave in response to those challenges. And we've taken that from Beck's Cognitive Behavioural Therapy book, published in 2020. So CBT helps people identify their thoughts and their feelings and their behaviours, and also to develop new coping skills and strategies for dealing with distressing situations or symptoms. And through that process, the person learns to change any negative thinking patterns or unhelpful behaviours that might be contributing to or maintaining their problems. CBT takes a holistic approach, and it actually explores 5 interconnected areas of any problem. So it looks at the person's thoughts and beliefs, their physical symptoms and body sensations, their feelings and emotions, their behaviour and actions, and also their environmental factors, life stressors, or triggers for symptoms. So menopause-specific CBT, according to NICE in their NG23 guidance, may be offered face-to-face or remotely, either one-to-one or in groups. And there are also self-help options. But Nick, what's the evidence for CBT in the menopause?
Okay. Well, NICE based their recommendations in their latest guidance of NG23, which was updated in 2024, on an evidence review that looked at 14 randomised controlled trials. Now, the strength of the evidence was relatively low quality, but NICE felt that CBT is a safe intervention with few adverse effects compared with other treatments, and so it can be recommended despite the lack of clear evidence. In the written Pearl, there's a handy table that summarises it all, but to run through the main points now, so for vasomotor symptoms and anxiety, NICE says that we should consider offering menopause-specific CBT for vasomotor symptoms associated with the menopause. CBT face-to-face or self-help reduces the impact of vasomotor symptoms by around 50% compared with control and is associated with improved mood, sleep and quality of life, and that's from the British Journal of Health Psychology. CBT delivered by specialist nurses can also improve vasomotor symptoms, sleep, anxiety and mood in women following breast cancer, and that's from Psycho-Oncology in 2020. NICE didn't make any recommendations about treatment of anxiety during the menopause, and the evidence review didn't show any clear benefit of CBT. However, patients with a diagnosed anxiety disorder should be managed according to the NICE guideline CG113 from 2011, and this takes a stepped approach that typically begins with self-help and low-intensity psychological interventions and then moves on to high-intensity CBT or drug treatment for more severe or persistent symptoms. Our article, Generalised Anxiety Disorder on Redwell Knowledge, has got more information.
If we consider the evidence for sleep problems now, NICE also recommends CBT for menopausal sleep problems, including nighttime wakening. CBT for insomnia, or CBT-I, has been shown to improve sleep in peri- and postmenopausal women with insomnia and vasomotor symptoms. That comes from Sleep Journal in 2018. And both CBT-I and sleep restriction therapy can improve fatigue, energy, sleepiness and work function, with CBT-I showing additional benefits in emotional well-being and better resilience to physical and emotional problems. That's from the Journal of Clinical Sleep Medicine in 2019.
Depression and depressive symptoms now, and NICE recommends that we consider CBT for people with depressive symptoms in association with vasomotor symptoms, either in addition to other management options or as a sole treatment if other options are contraindicated or people don't wish to try them. For people experiencing menopause who are suspected to have or have been diagnosed with depression, we're recommended to follow NICE's guideline on depression in adults, which is NG222 from 2022, in conjunction with menopause guidelines. Treatment options are based on the severity of symptoms, and our depression article on Red Whale Knowledge has got more details.
And finally, looking at concentration and memory problems, the Journal of Affective Disorders in 2024 suggested that CBT may lead to a small but significant improvement in memory and concentration difficulties.
So how can we access CBT for the menopause, Ali?
While CBT has been emphasised as a safe and potentially effective treatment by NICE, access to menopause-specific CBT is extremely limited in much of the UK. NICE acknowledges that its recommendations represent a significant change to current clinical practice, and it highlights the fact that wider use of CBT is likely to increase costs and add pressure to already limited services, but also points out that this gives people more choices for managing their symptoms, including the option to combine CBT and HRT, which may lead to better outcomes.
As awareness of the potential benefits of CBT grows, it's likely that there will be increased patient demand for menopause-specific therapy. However, significant investment in psychological services will be needed if we're to offer treatment choices that are in line with the latest NICE guidelines. For many with limited or no access to menopause-specific therapy, then the only option may be to signpost to self-help CBT books, which may offer some benefit, and there are some recommendations in the useful resources section at the end of the written pearl.
CBT has been specifically adapted to help women cope with common symptoms that can arise during the menopause, such as vasomotor symptoms, anxiety and stress, depressed mood, and sleep problems. So we're going to explore these areas in more detail, and there's a really useful fact sheet aimed at patients produced by the Women's Health Concern, which looks at vasomotor symptoms and anxiety, depressed mood in the menopause, and sleep problems and insomnia. So let's look at these in turn.
Yes, so if we start with vasomotor symptoms and anxiety, vasomotor symptoms such as hot flushes and night sweats can be unpleasant and distressing and lead to feelings of embarrassment and anxiety, as well as causing discomfort and affecting sleep. Conversely, being anxious and stressed can make vasomotor symptoms more difficult to cope with. Feeling anxious about vasomotor symptoms may be associated with negative or unhelpful thoughts, which focus on worst-case scenarios and underestimate the person's ability to cope. And so this may include beliefs about hot flushes in social situations. People might think they're embarrassing and shameful. Fear of being judged negatively by others. It might be thinking, everybody's staring at me, I look like a tomato, my boss may think I'm completely rubbish. So all those things can come to mind when this happens. Beliefs about lack of control. I can't cope with this. The hot flush will go on forever. All of those things can come into your mind. And also catastrophic thoughts about the meaning of menopausal symptoms as well. Now, unhelpful behaviour in response to vasomotor symptoms includes avoidance of feared situations and setting unreasonable expectations or pushing too hard and getting exhausted, so boom or bust. Managing anxiety and stress can improve overall well-being and reduce the impact of vasomotor symptoms on daily functioning. So if we use the CBT framework of vasomotor symptoms, then we can use that to explore how vasomotor symptoms can cause emotional distress with negative thinking and unhelpful behaviours. So in the written pearl, there's a really useful infographic on there. And in the middle of it, it says environment or triggers. So that would be things like working in a hot or unventilated office, stressful or social situations, something like that. And then around it, we've got thoughts. So things like, I look awful, everybody's staring at me, I can't cope. And then that could then lead on to physical symptoms, things like sweating, feeling hot, heart racing, churning of the tummy, all that kind of stuff. That can then lead on to behaviour. So avoiding stressful situations, leaving the room. And then that can lead on to feelings of feeling embarrassed, anxious, or out of control. And of course, all of those things that are interlinked could be interlinked in any direction at all. So feelings of being embarrassed and anxious could also then lead on to thoughts that I look awful. So if you look at the infographic on the written pearl, it can go in any direction, which is actually really interesting to look at. Now, a CBT approach can help people to develop a calmer, more realistic or accepting view of situations and symptoms, making them easier to cope with. So we're going to explore some strategies to encourage positive change later in the article. Now, what about depressed mood in the menopause, Ali?
Yeah, so low mood is not inevitable for women going through the menopause, and actually for some, menopause is a positive experience, but menopause transition can sometimes be a trigger for the development of depressive symptoms, and that's particularly true for women who have a history of depression. And the life stage that menopause occurs in has a lot of common life stresses and problems. Examples of these include having a busy or demanding lifestyle, juggling pressures at home and at work, coping with adolescent children or older children leaving home, and at the same time experiencing bereavement or ill health in parents or elderly relatives. And that can combine with depressed or self-critical thinking styles, so negative beliefs about the menopause and ageing, feeling like we're old, invisible. Menopause meaning that life and your health are on a downward trajectory. Beliefs around loss of fertility and changing roles. Some women feel worthless, for example, or lose some of their sense of self-worth when their children leave home, and other self-critical thinking styles, maybe about appearance and attractiveness, feeling good in your body, that kind of thing. So thinking about these areas of the CBT framework can combine with physical symptoms, fatigue, tiredness, pain, poor sleep, and emotions, so low mood, sadness, hopelessness, and behaviours, so maybe reducing activities that give life a sense of purpose and meaning, maybe withdrawing socially, becoming isolated, that kind of thing. So we see how all of these things combine. So what have you got specifically about sleep problems and insomnia, Nick?
Hot flushes, life stresses and low mood can all affect sleep in perimenopausal women, and this causes tiredness and increased distress and can have a negative effect on performance in important activities such as work. Now, insomnia is characterised by difficulty getting to sleep or staying asleep, early awakening or non-restorative sleep despite adequate time and opportunity to sleep. Also, impaired daytime functioning, for example, poor concentration, mood disturbance or tiredness or significant distress. Worry about disrupted sleep often creates anxiety at bedtime, which makes sleep even less likely. This includes negative beliefs such as, if I get woken up by a night sweat, then I'll never get back to sleep. I'll feel terrible the next day and I won't be able to cope. Behaviour that can worsen sleep includes having an irregular sleep pattern or routine, frequent daytime naps, engaging in activating activities at bedtime that make it harder to drop off, and excessive clock checking at night time. CBTI involves a range of strategies which I'm about to run through. We've included a link to useful resources at the end of the written article and associated Pearl on Redwell knowledge, and I'll also put a link in the show notes. So here are those CBTI strategies. So sleep, education and hygiene. Sleep restriction, so limiting the time in bed and reducing daytime naps to consolidate and improve sleep quality. Also stimulus control, establishing a consistent sleep routine and limiting activities in bed to strengthen the association between bed and sleep. So other CBTI strategies would be relaxation training, also strategies to cope with hot flushes and night sweats, and cognitive restructuring of unhelpful thoughts or beliefs about sleep. So what have you got on physical activity in the menopause, Ali?
Well, we know that physical activity is likely to lift low mood, and it might also have a positive impact on vasomotor symptoms and on sleep. Many physical activities also encourage social interaction and mutual support. A national survey in 2018 explored women's relationship with sport and physical activity during the menopause. This is the Women in Sport, Menopause, Me and Physical Activity survey. And these are some of its findings. 30% of women reported becoming less physically active since menopause, yet the desire to be active is really high among these women, and it's even higher if physical activity is recommended by a health professional. So definitely a role for us there. It was found that physical and emotional changes during menopause can lead women to experience feelings of loss, including a lack of control over life and a loss of sense for self. And this was more apparent for non-physically active women. Barriers to participation in physical activity included menopausal symptoms, low exercise self-efficacy, and physical activity knowledge, as well as social stigma and lack of social support. And menopause was found to be a powerful prompt for women to change physical activity behaviour. And active women actually felt more empowered to take control of their lives and to manage their symptoms and long-term health through exercise.
We're going to finish off by looking at a CBT strategy to improve menopausal symptoms. Now, we haven't got time to cover all of the CBT strategies here, and there are many more in the written pearl. So we're going to look at our personal favourite, which is relaxation and paced breathing. Now, paced breathing can help calm feelings of anxiety and distress, and it can be used as part of a wind-down routine to help with sleep at night, or it can be used during the day to soothe distress about symptoms such as hot flushes or brain fog. So this is how we do paced breathing. So when you feel a hot flush coming on, then paced breathing can create a pause and help to calm your body and mind. It involves focusing on your breathing to reduce anxiety and distress. So here are the steps, and I'm going to do this in the style of a self-help audio download from your favourite self-help book. And I should say, don't attempt to do this exercise if you are driving or if you are operating machinery, and certainly don't close your eyes if you are driving or operating machinery. So here we go. Try to find a quiet place with few distractions where you can sit, stand, or lie down in a comfortable position. Gently close your eyes to help you focus on your breathing. Place one hand on your tummy and another hand on your chest. Take a slow breath in as you count to 4. Push out your tummy as you breathe, allowing this hand to rise upwards. Keep your chest and shoulders as still as possible. Hold your breath for a count of 4, noticing any sensations in your back or your chest. Now slowly exhale for a count of 6. Imagine releasing any tension and heat with your breath. Pause for a count of 2 before breathing in again. Allow your body and mind to relax. Repeat this cycle of breathing for a few minutes until you feel calmer and more settled. Then let your breath out slowly one last time and continue with any important activities in your day.
Oh, Nick, I'm feeling so relaxed now. That was lovely.
I hope that was okay. And I hope you're feeling relaxed listening to this as well. So there we go.
Yeah. So now we're all feeling nice and relaxed. It's time for our take-home messages on CBT for menopausal symptoms. CBT can be effective in helping women cope with a variety of menopausal symptoms, including low mood, anxiety, sleep problems, and vasomotor symptoms.
Physical activity is likely to lift low mood and may also have a positive impact on vasomotor symptoms and sleep.
Relaxation and paced breathing can help calm feelings of anxiety and distress.
Now, if you're hankering after a Redwell Knowledge subscription, then we're offering a 10% discount on Redwell Knowledge for our fabulous Redwell Pod members. And so how do you become a member, I hear you ask? Well, if you're listening to us right now, then you are part of our pod. So hello. Now, all you have to do is go to redwell.co.uk, put Redwell Knowledge in your basket and enter the code RedwellPod to get 10% off. And here's a small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and it's all lowercase Redwell Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we would really appreciate it. And if you can spare a little more time, then please leave us a nice review. Because of the way algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, then there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Tell everybody that you know who might benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want us to see something about the podcast, then please use #RedwellPod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Redwell Knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.